Okay, thank you very much. Thank you for the organization, and thank you, Stefan, of course. So it's very hard to cover, how to read clinical trial reports and what to look at in 30 minutes, but I will try to cover some of the core aspects I think are very important when interpreting clinical trials. So you have no conflict of interest, and what we will be covering is the control arm. You will see that the control arm is not always the best standard of care that it should be. Then we will be talking about post-protocol care, sometimes called also subsequent therapy. It's also very important. It's, in a sense, affecting the control arm down the road. Trial design aspect, and this will be pretty short, and then we'll try to spend some time about endpoints and informative censoring. You will see how important it can be, and it's too often neglected, as it was said by Jan Tannock. So what should be the control arm? And we have some guidance from the Helsinki Declaration. This was updated 1 year ago, a bit more than 1 year ago. And as you can see, by enrolling your patient should not, the research should not take precedence over the rights and interests of individual research participants. In other words, if you are enrolling a patient in your trial, and by being in the control arm, the patient is receiving suboptimal care, the trial is not optimal. This is pretty straightforward. You would not enroll your friend in such a trial, but I think it's always a question to ask yourself. Also, new intervention must be tested against those as the best intervention. This is not talking about placebo. Placebo is a bit another topic, but in other words, the control arm should be the best standard of care. Now, the first example in breast. So, I had to find really breast example. There will be one non-breast example during the talk. So this was the ASCEND trial. I think you all remember this trial. This was patients with triple-negative breast cancer, metastatic triple-negative breast cancer. And as you can see, the patients were, I won't use that. The patients were heavily pretreated with at least 2 lines of chemotherapy in the advanced setting. And in one arm, you had sacituzumab, and in the other arm, treatment of physician choice. And here, my question, what do you think about this physician choice? Is it a free choice? It looks good, you have a choice, and that's really the question that we look at with Vinay Prasad and Alison Aslam. Basically, we took all trials in oncology that were referring to the control arm, referring to investigator choice or physician choice. And what we found was it's really a recent trend, started in 2007, and it's increasingly used, as you can see on the graph. And most of these trials are industry-sponsored, and most are restricted choice. So it's basically 85% of them are using a restricted choice. Now, I hear you can say, okay, Timothée, it's a restricted choice, but if you are offering a lot of choices, what is the problem? So here, for instance, there were 4 choices: eribulin, vinorelbine, capecitabine, gemcitabine. And as I told you already, these patients were heavily pretreated, at least 2 lines of chemotherapy in the advanced setting. So why I'm complaining about that? Then you should be very careful in studying every option that you could consider for this patient. For instance, platinum-based chemotherapy was not allowed, and 31% of patients were not treated, and we know it's an important option in triple-negative breast cancer. And anthracycline, it's also a backbone in breast cancer treatment, and 17% of patients were untreated. So this is one point to look at. If we go even further, and here you should really look at the supplement, and sometimes it's a bit challenging, it's time-consuming, of course, but still in the ASCEND trial, we looked at one type of toxicity. And what was the dose reduction and G-CSF rules for this toxicity? If you were in the new therapy, sacituzumab, for the next cycle, no dose reduction and mandatory G-CSF. So of course, this will allow to have a higher dose intensity. You don't have a dose reduction. On the contrary, if you were in the single agent chemotherapy group, for the next cycle, 1 dose reduction, and G-CSF were per physician discretion. What does that mean? We know that these trials are conducted globally. So in some countries, G-CSF are not available. So maybe there are some patients that receive a lower dose, and in a sense, it's favoring the experimental therapy. So again, you can say, okay, Timothée, you have seen this is an example, you take one example like that. We studied this comprehensively over more than a decade of FDA-approved drugs, and basically we selected all trials where we could compare the dose modification rules and GCSF rules. And what we found was in 55% of trials, the rules were favoring the new therapy, and in only 10% it was favoring the old therapy, the control arm. So our conclusion is, in those cases, it was impossible to know whether the new drug was truly better or if the outcome were achieved by higher dose intensity. So to me, the suboptimal control arm is this image. You have a race, someone is winning, but he had an advantage at the beginning, so you don't know if the winning was, really because he was winning faster or just because of the advantages. And actually, it's not so rare. This was also a study from 2013 to 2018 for registration trials in the FDA, and it was seen in 17%, so almost 1 out of 5 trials used a suboptimal control arm. So here are my key points about the control arm. You should always ask yourself, is it best available care? Physician choice is very often that you will be seeing physician choice in New England Journal of Medicine paper. I think you all know that. You really have to think, if I have my patient here, what option that I would like to have, and are there important options that you don't have? Dose reduction and supportive care rules, it's important. You have to dig in the supplement. Then post-protocol. So post-protocol, I think that the most correct term would be subsequent therapy. So there are many terms: post-protocol, crossover, post-progression. So post-progression is when you have an advanced disease. When it's neoadjuvant or adjuvant, it's post-recurrence because you don't have any more a disease. So if you have a recurrence, it's not post-progression. Post-trial subsequent therapy. For crossover in oncology, we are really designating a unidirectional crossover. Basically, patient in the experimental arm and patient in the control arm will have access to the experimental therapy upon progression or recurrence. If you are interested about crossover and when it's good and when it's problematic, I really advise you to read this paper from Islam and Vinay Prasad. It is really giving a very nice framework. I won't go into the details of this paper, but I really like to cite it because I think it's a very important paper. I want to focus on one point about post-protocol. The lack of access to best care post-trial for control patients. So that's what I was telling before, you're penalizing your patient down the road, not in the first line, not during the control therapy, but second line, third line, and etc. And of course, this won't affect your DFS, this won't affect your PFS, but this can affect your overall survival. And it's still, deemed the most relevant endpoint in oncology. So when you have an overall survival benefit, I think post-protocol should really carefully be studied. So we will be talking a bit about adjuvant CDK4/6 inhibitors. So is it a hot topic? Of course, it's a hot topic. This is a recent study. Basically, Monarchy and Natalie could affect up to 38% of newly diagnosed breast cancer, and breast cancer is one of the highest incidental cancer in the world. So we all know that Monarchy is higher risk patient, Natalie has broad eligibility criteria, and I will first talk about Monarchy. Why? Because during SAMO, and it was published the same day, we had an overall survival gain reported in Monarchy. So Monarchy, I will go fast, maybe this will be addressed in the talk, but these are hormone receptor positive patient, HER2 negative patient, high risk according to some criteria, and it's an open label design, and they are receiving 2 years of adjuvant abemaciclib or something else. Or standard of care, sorry. And here, the question to me is adjuvant abema or patient, it's working, or patient in the control arm not receiving abema we know that CDK4/6 inhibitors are really part of the first line. I mean, we could discuss about Sonia, but we know that CDK4/6 inhibitors are really part of patients that are presenting a recurrence. There is some issue with the mic. Sorry. I don't know if you hear me well.
Yes.
Try this one.
Better? Yeah. So to me, the right question is this one, and sometimes when you do the right sequence, maybe you won't have an overall survival benefit, maybe you can have an overall survival benefit, but I think you should have a proper access to best care for patients in the control arm that will present a recurrence. What would be problematic is you receive adjuvant abemaciclib, and then in patients with the control arm, for those that will be presenting a recurrence, they have a limited access to CDK4 inhibitor. And then this is penalizing your patient in the control arm down the road. So did this happen in the Monarchy trial? So this was published, I think, the same day as the presentation during SAMO, overall survival with abemaciclib in early breast cancer. So the first thing I want to say is 1.8 absolute benefit after 7 years. This means a number need to treat of 55. This means that 55 patients need to be prescribed. I said be prescribed because they won't receive all the entire treatment. Some won't tolerate the entire treatment, but need to be prescribed 2 years of abemaciclib to save 1 life after 7 years. I think this kind of statistic, this kind of wording, the number need to treat, is important to share with patients. I mean, this is a shared decision making, you know, it's not nothing. Now my question, it's about the validity of this overall survival benefit. And let's look at post-protocol treatment. Here, in the control group, we know that this number of patients received some first systemic therapy. We also know that this number of patients received CDK4/6 inhibitors as this first systemic therapy. So doing some calculation, you can infer that 204 control patients received a systemic therapy that was not CDK4/6 inhibitors. So this is making 7.2% of control of patients. So 7.2% of control of patients received the subsequent systemic therapy that was not containing a CDK4/6 inhibitor. And if you put that on the same graph, and I have to zoom even more. But my question here, you know, and we don't have the answer, you know, it's only a hypothesis, but would an overall survival benefit have been observed if at least a fraction of those 7.2% had access to CDK4/6 inhibitors upon recurrence? Now, I hear you again. You may say, but what happened, Timothy? Why this patient did not receive a CDK4/6 inhibitor? I mean, the doctors are bad doctors, or what is happening? Somebody has the answer of that? I know you don't need. Anita, you no, not Anita. Does anyone have a clue why this is happening?
Depends on the country.
Yeah, the country. This is the key. How is this possible? This is because these trials are global trials, and as you can see, some, you know, Russia, Ukraine, and other countries. You have countries where there is no the best care available for patients that will present a recurrence. And to me, this is problematic. This is really the elephant in the room, global trials with an ethical dilemma, because these studies are run mostly to gain approval for countries where you have access, and they are run in those countries, possibly driving survival gain. We looked at this comprehensively, and in the adjuvant setting, basically, the first thing I want to say, Monarchy was very good because it was reported. In many instances, it's not reported at all. So it was reported, and as you can see, in many cases, it was either not reported or not optimal, and we did the same kind of work in the metastatic setting, and basically, as you can see, only 12% of FDA approvals between 2018 and 2020, had available data assessed as optimal. So it's really a widespread problem in oncology. So my key points about post-protocol, it may affect overall survival. It really questions the trial's validity in settings where optimal care is available. If we are talking about Monarchy, I mean, I don't know if the survival benefits seen in the trial will replicate in our practice. I mean, in Switzerland, where we have all the data. I don't know. I don't say it will not, but I don't know. And I think that is the key ethical dilemma posed by global trials. Now, trial design. I will try to be pretty fast on this part to have some time for endpoints and informative censoring. First, you should always be cautious about observing a huge effect in early phase trial, because this can be due by chance alone. An example I found in breast was, maybe somebody remember that? Anita is saying yes. So it was in triple negative breast cancer, gemcitabine carboplatin plus ipilimumab, sorry. And in the phase 2 trial, as you can see, there is another survival benefit, and it's statistically significant. But in the phase 3 trial, it was totally called negative. Now detecting a statistical difference, which is not really clinically meaningful, and here, that's the only example I take from digestive oncology in pancreatic cancer. I tried to find one in breast, but I couldn't find such a striking example. This was erlotinib plus gemcitabine compared with gemcitabine alone in patients with advanced pancreatic cancer, and the median, still it was significant, and your p-value is less than 0.5, but it's not just the median. Sometimes the median is very close, but you can have shape of the curve, but here you can really see the curves that are almost superimposable, and it was 11 days of improved median, and this was not, I think, a real success. Now you should always look at the rules, and if you have change in the protocol, change in the sample size, you should worry about that. This is called Texas sharpshooter fallacy. Basically, you look at the data in many ways and you choose what fits your narrative. So this is also data dredging, p-hacking, but you can check that on clinicaltrial.gov and in the protocol. Now, one word about blinding or open label. This was really studied empirically that when it's open label, you will tend to exaggerate effect estimates. And in a sense, that's pretty natural. Let's say you have a trial where you have a new drug, you are really convinced by the efficacy of this new drug. Let's say, the CAT scan, the CT scan is more or less 20%, but maybe a bit less, maybe a bit, but then you have your patient, you will maybe delay calling the progression. If you know your patient is in the control arm with maybe no therapy at all, you will maybe call a progression earlier to drive the patient in another trial or to propose the patient another treatment. So you can really see that subjectively, and this is normal, I mean, this is natural, we are humans. So that's why I think we should always aim to randomize, to blind design when it's possible. So this is my conclusion about trial design. Be aware of false positive findings in phase 2 trials. This point I already talked about. Sample size should be neither too big nor too small. When it's too big, you can find statistically significant trivial difference. I think this is a problem with the inflation of sample size and blind open. Now, which endpoint was used? So you are still with me? Yes. I'm still on time here. So I think to me that's one of the most important parts because it's very too often neglected, and as you will see, it can really have an impact on outcome. So let's take the example of progression-free survival. As you can see, there are many articles, meaningful or simply measurable. Progression-free survival, is it time for a new name? Progression-free survival should not be used as primary endpoint for registration of anti-cancer drugs. So it's a long and still ongoing debate. I'm not saying I will settle the debate, but I think what is very important is to understand what is progression-free survival and disease-free survival. And we'll take an example, recent example, 2026 New England Journal of Medicine, the PATINA trial, palbociclib for hormone receptor positive, HER2 positive advanced breast cancer. So this trial included patients with HR plus, HER2 plus metastatic breast cancer with no prior treatment in the advanced setting, 6 to 8 cycles of treatment, including trastuzumab plus or minus pertuzumab and taxanovimab. They should have completed the induction chemotherapy, no evidence of disease progression, and basically it's a maintenance trial with palbociclib with trastuzumab plus or minus pertuzumab plus under cryotherapy, or the same without the palbociclib. It's an open label design, so your investigator, you are the investigator, you know if your patient is using palbociclib or not. Now you have a progression-free survival benefit. It's the median improvement is 15 months. So yeah, it's a positive trial. There is no survival benefit seen yet, but the data are not major. So it's a good example you will see. So PFS is a composite endpoint. What does that mean? That means that you have many types of events that can count as an event. You have death, that's why it's called progression-free survival, but also new CT scan lesions, or these progression based on CT scan threshold. Classically, you know, the 20% increase in diameter is a progression, or you have first a response and then a progression. So all these can count as an event, whichever occurs first. And this is very important, because when you see the curve, it's not written if the event was a death or it was an asymptomatic progression. Also, it's a time to event composite endpoint, meaning that the time when the event will occur will shape the curve. If the event occurs after two months, it will make a first step, and you see the example. And the other thing, what is important, is censoring. Censoring is a time for patient after which you cannot recapture the event. So in general, there is administrative censoring. For instance, your patient is still on trial ends, and so you have to censor the patient at the last follow-up. But you can also be censored for other reasons, like you did not come for doing your CT scan, or you change therapy before assessing for progression, and think about it. This can explain what we call informative progression, because why you would not come for doing your CT scan. PFS is correlating with survival? In general, no. This was a trial, so in general there is poor correlation. In some setting, very specific setting, there is a good correlation, but in general it's not a good correlation. Is it correlating with quality of life? The answer, again, is in general not a good correlation. So again, I want to highlight that death or an asymptomatic 21% increase in tumor size on a CT scan is not at all the same. And yet, you know, the recounting, the breakdown of PFS is very, very rarely reported. This was a work done by Anushka Valia and colleagues, and they showed that in the vast majority of cases, the breakdown was not reported. And why I think it is mattering. When you say progression-free survival to your patients, why do you use the word survival? Because there is a death among all these events. But when you say progression-free survival to a patient, he really feels he will survive longer. But this is not true. I mean, this is not the definition of the endpoint. The definition of living longer is overall survival. So in PATINA, back to PATINA, in PATINA, you have a clue. And this is one first tip for informative censoring. Always try to go to the consort diagram. And as you can see, you have 2 patients discontinuing treatment and 1 discontinuing treatment, the other arm due to death, but most are discontinuing treatment due to disease progression. So in PATINA, we have an indirect clue that most PFS events were disease progression and not death. So to me, it's recontextualizing this word, survival. I think that was the reason why some people wanted to change the name. I don't know if that's a solution, but I think that's very important. So now we will be keeping talking about PATINA for another point, which is called informative censoring. As you can see, still in the consort diagram, in the control arm, so in the patient in PATINA that did not receive palbociclib, 11 patients did not start the treatment at all. In the experimental therapy, everybody, started the treatment. So it's already 4% of immediate dropout. Immediate, they left the trial. Why so much early dropout? And this is, I think, the key slide. There's 2 types of reasons why you will drop out a trial, and this is really in what we call informing censoring. If you are dropping out the trial because of toxicity, increased toxicity. Maybe you won't be able to come back to do your CT scan. Maybe you are a frailer individual and maybe you are at higher risk of presenting the event. But because you are censored, you are no longer in the curve. So this may selectively retain lower risk patient and then will favor the experimental arm in general when it's more toxic. This is really the classical way of informative censoring, but there is another reason. The other reason is disappointment-driven censoring. Here, it's mainly in the control arm. For instance, this patient in palbociclib, she was told that the trial was very interesting, and now she's on the control arm. She doesn't have access to palbociclib. Maybe she will say, oh, it's not interesting to me, I'm in the control arm. Maybe I'm interested to go in another trial, competing trials. And what do you think these patients are? Are they the same, that patient remaining in the control arm? No, they may be more connected with higher socioeconomic status, and they may, it's a hypothesis, but they may have a lower risk for the event. So if that happened, again, this may selectively retain higher risk patient in the control arm. And sometimes you can have both. If we take patina, this is again hypothesis, I don't know, I don't have the data, but hypothesis based also on the treatment received and based off this early dropout. If you have toxicity in the experimental arm, this can, retain individuals with a lower risk of event. And if you have disappointment in the control arm, this can do the reverse. So this can really amplify or sometimes even fabricating your outcome. And this is the definition of informative censoring. So now how to explore it? One thing first, normally, you have censoring numbers. Normally, ideally, you would have censoring numbers reported in the reports. The Lancet group is doing it systematically, and New England, it's not systematically. But there is a way to get those number estimates, even if you don't have them. And this is where I will introduce you this application that I've developed with my colleagues, the Breaking Ice application, where you can digitize the curve, and then you will have estimates of the censoring numbers, and then you can also do some sensitivity analysis on them. And you will see that with very little assumption, you can modify your outcome. So here is the original curve. I just want to show you that the digitalization is pretty good. This is superimposition. This is what I get with the application. Now we have the number of censored patients, and as we can see, there is an early excess of dropouts in the control arm, but not just the first patient that did not even, started the treatment, but even in the first 6 months, with 12.1% versus 5.7%, which is pretty significant. Now, how we can explore? We can artificially modify the status of some censored patient in both arms. If you say that some of those had toxicity-driven censoring, you modify the censoring into events, and if you say that they were disappointing, you modify the censoring into late censoring. And if you do that, here you only modify 2 censored patients in the experimental group, 5 in the control group, and your result is no longer statistically significant. Last, in the adjuvant setting, and also I wanted to refer, because I talked about palbociclib, and I have to talk about ribociclib. So the Natalie trial, so broader eligibility criteria, and now it's 3 years of adjuvant treatment. Primary endpoint is still EGFS. And after the Natalie trial was published, we already published a sensitivity analysis showing how informative censoring could have impacted the results. But now we'll do the same sensitivity analysis, which is an update after the 5-year survival, 5-year update that was presented during ESMO and published the same day in ESMO Open. So here again, I want to highlight that the 4.5 difference of EGFS is still translating into a number need to treat of 22. So 22 patients need to be prescribed 3 years of ribociclib to prevent 1 EGFS event after 5 years. Again, I think it's important data to share with patients when you consider those treatments. But again, I would just want to show you after 6 months, you still have an This is now with longer and longer follow-up. When you have very early data, it's possible to have high early censoring because your data are not very immature. But when you have long-term follow-up, you can really see the rate of early censoring. And you see that after 6 months, it's still significant in both arms. And here again, with some assumption, again, it's hypothesis generating, no longer significant. And what we said in our paper after the Natalie publication is that the benefit is fragile, prone to informative censoring in open label trials. Does informative censoring is a hot topic? This was the first review of Monarchy by Tomer, Meyerson, and colleagues. This was our publication after the Natalie trial. Other papers that are very interesting and push back with some authors that are disagreeing with us, also conducting various sensitivity analysis. But informative censoring actually now is a hot topic. So I think it's a good thing that people are considering this as a key element in trial appraisal. So the conclusion, overall survival is a direct clinical endpoint. PFS is not. It's a composite endpoint. GFS is not as well. It's again a composite endpoint about various definition. PFS and DFS, I think, are prone to informative censoring. And some tips to explore informative censoring: check the consort diagram for early dropouts, censoring number when you have them, and you can use breaking ice application. And you can also write to me if you need to explore one trial. One of the last slides, shared decision making. Give it to me straight, doc. How long do I have to ignore your advice? I don't think this is the best way of doing shared decision making, but it needs time to republication, of course. It needs time with patients also to explain. You cannot explain all this uncertainty, all these details in 5 minutes, saying, okay, this will prolong your progression-free survival, please take this pill. Explain the data, visuals may help. Also, don't reject the data. Here I was invited, I didn't choose a title, I was invited to speak about that, but it's not a rejection of all the data, but this can really help also to refine your decision-making with patients, particularly when you are in some gray areas. So, in conclusion, you should really focus on the control arm, post-protocol, study design, and informative censoring. I think you will remember that now. And friendly advices: develop and maintain your ability to critically appraise the data yourself. I know it's time-consuming, and it's not a skill. I won't say it's not a skill. It's really at the core of clinical medicine. We had great talks by surgeon, radiotherapy, pathology. Everybody is really involved in this job of reading papers, interpreting the literature. I think this is at the core of what we are doing. Also, this is enjoyable. It gives more meaning to what you are doing when you think you are understanding maybe more precisely what is going on, even with all this uncertainty. And what I said already about the decision making. I just want to thank my chief, Professor Alfredo Adeo, Professor Vinay Prasad, which is now CBR director, which I worked with on many projects, patient, Geneva Analytics Committee, which I joined, some project. My website, research website, there is an oncology shot, which is a letter. You can subscribe for free, and you will receive some content in the mood of what I presented today. And you can contact me if you have questions. And thank you for your attention.